Alois Alzheimer, a German psychiatrist, described a female patient known as D. Auguste. She was aged 51. She initially developed psychotic delusions of jealous type, accompanied with auditory hallucinations. This condition soon progressed to cognitive disturbances of memory and speech. Alzheimer described the clinical features and autopsy findings in 1907. The disease itself was named Alzheimer's disease. Alzheimer noted the gross atrophy of the brain with widening sulci and narrowing of the gyri in the cerebral hemispheres. Significant changes were in the hippocampus, temporal cortex, the nucleus basalis of Manet, and in the thalamus. The ventricles were dilated. Under the microscope, he observed neuronal degeneration. This is a structure of a normal neuron, showing the nucleus, the cell body, the axon terminal, and dendrites. Under the microscope, he observed the neuronal degeneration and extraneuronal deposit of amyloid material surrounded by degenerate dendrites. They are also called neuritic plaques. Neurites are projections from the neuron, example, dendrite or axon. He observed the degeneration of neurofibrils within the neuron and formation of neurofibrillary tangles. Though these changes had been observed in the elderly, its occurrence in a patient aged 51 attracted attention. The disease is seen in 5% of those over the age of 65 and 20% of those over the age of 80. Age-specific incidence is same for men and women, approximately women showing 50% excess prevalence, explained by the greater number of risk women living their longer life. So the female-male ratio is higher for the females. The characteristic features of Alzheimer's would be called degeneration of neuron, extracellular amyloid deposits, amyloid angiopathy, and neurofibrillary tangles, and cholinergic disease. These are the hallmark of the disease. Electron microscopic evidence shows that the neurofibrillary tangles appear as paired helical filaments. Tau is a microtubule associated protein that stabilizes the microtubules that convey glycoprotein to cell organs. In AD or Alzheimer's disease, This protein is hypophosphorylated, as shown in the earlier slide, and leads to the formation of fibrillary tangles. Amyloid plaques contain a toxic form of beta amyloid, beta amyloid 42 with amino acids. The pathophysiology of amyloid, the function of amyloid, is not clear. The amyloid is derived from a longer chain called amyloid precursor protein, a transmembranal protein seen across all cellular membranes. Amyloid is derived by cleavage at its transmembranal domain. Amyloid precursor protein is believed to be involved in synaptic formation and regulation of neural plasticity in the central nervous system. Number of genetic mutations have been identified in amyloid precursor protein gene predisposing to formation of beta amyloid found in the plaques. Enzymes named alpha secretase, beta secretase, and gamma secretase are involved in cleaving at the transmembranal region of the APP to produce beta amyloid. In doing so, they may produce beta amyloid with 40 amino acids, which is called beta amyloid 40, or beta amyloid with 42 amino acids, called beta amyloid 42. Beta amyloid with a chain of 42 amino acids is seen in amyloid plaques and is considered to the pathological or toxic element, to be the pathological or toxic element. It is believed that 42 amino acid chains show abnormal folding, resulting in easily precipitable protein. Whether the plaque formation or the fibrillary degeneration is the primary process is at the moment not clear. Genetics. It has been observed that patients suffering from Down syndrome, dementia as early as 40 years or 50 years, their brains show extensive deposits of amyloid plaques and neurofibrillary tangles. Down syndrome associated with the trisomy 21 is interesting, as the APP gene is located in chromosome 21. Mutations of APP gene have been reported and appear to be an uncommon cause of familial AD. It was mentioned before that APP was cleaved by three enzymes: beta secretase, gamma secretase, and alpha secretase. Beta and gamma secretases cleave to beta amyloid with 42 amino acids, while alpha secretase, which cleaves beta amyloid with 40 amino acids, is responsible for normal function. Gene for gamma secretase is called presenilin-1. The mutations here is held to be responsible for more than 50% of early onset Alzheimer's. The gene is located in chromosome 14. Presenilin-2 is a gene located in chromosome 1 and determines the formation of a membranal protein. Mutations here account for the rarer causes of early onset Alzheimer's disease. Early onset Alzheimer's disease is characterized by a strong family history and only forms 5% of all the Alzheimer's disease patients. Beta secretase is a membranous protease. It is called beta site APP cleaving enzymes or base. Inhibitors of the enzyme have been trialed. No mutations were known until recently. A Swedish study reported a mutation in the Golgi-derived vesicle. Alzheimer's disease in older patients is associated with a gene in chromosome 19, which influences the production of a lipoprotein called ApoE. This lipoprotein transports cholesterol. There are 4 types of ApoE lipoproteins having E1E1, E2E2, E3E3 or E4E4. Now E4E4 has the highest risk of AD of old age. E1E1 is not found in humans. Other combinations are seen, E3, E4, E2, E3, etc. This accounts for about 15% of the Alzheimer's disease. As research progresses, more genes involved in the pathological process are being reported. Old age, family history, Down syndrome, ApoE gene mutations of genes involved in beta amyloid 42 increases the risk of AD. I think we should start this somewhere. Major depression, hypertension, brain trauma are risk factors for AD. Diabetes, intellectual disability, smoking, aluminium toxicity have all been implicated. Clinical features are divided into 2 groups. Cognitive defects are characterized by failing memory. Patients may misplace things or forget appointments or repeatedly ask the questions, having forgotten the earlier answer. At onset, primary memory or working memory may be spared. Example, patient may be able to immediately recall words or 5 span digits. He will not recall after a few minutes. This is due to his inability to convert registered information into symbols for storage. Hippocampus is responsible for long-term memory and is the region which atrophies first. This accounts for patients' inability to learn new information and disorientation in place, time, and person. Patient recalls incidents that occurred many years ago. However, he fails to recall recent events. With further progress, Alzheimer's disease, even the long-term memory is lost. Factual or declarative memory suffers before procedural and skill-related memory. When difficulties occur with perception of dimensions such as length, breadth, depth, patient is unable to recognize faces and pictures. Disorders of language. At onset, patient struggles to use appropriate words and circumvents by describing the use of the object instead of the actual word, for example. A knife. This is called circumambulation. He may not be able to name common objects. This is called nominal aphasia. Some patients may choose paraphasic methods and is called paraphasic errors by using related words. For example, rain may be, for rain, the word water may be substituted. When circumlocuulates the knife, patient might describe its use. Sometimes patient uses a word with similar sound but unrelated in meaning. Soon motor production of speech is impaired and grammatical errors are seen. Patient may perseverate by repeating an answer which was appropriate for an earlier question. This indicates frontal lobe involvement in the disease process. Echolalia is repetition by patient the sentence of the examiner. Palilalia is continuous repetition of the last word, and logoclonia is a continuous repetition of the last syllable. For example, the word quick may be mentioned as ik, 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 ik. Aprexia is a difficulty in performing complex motor tasks despite normal power, coordination, sensation, comprehension, and cooperation. Aprexia is complete inability to perform such tasks. Patient is unable to plan or organize movement and is unable to demonstrate how he would brush his teeth or cut with his knife, which is called ideational aprexia. Inability to dress is called dressing aprexia. Inability to draw shapes or construct figures is termed constructional aprexia. This defect is more than a defect in executive function and includes appreciation of length, breadth, depth, right-left orientation, indicating parietal lobe involvement. These defects will have serious consequences, particularly in driving and handling machinery. Agnosia. It is a failure to appreciate sensory information in spite of intact memory pathways and sensorium. Tactile agnosia or astereognosis, the inability to recognize form, texture, and shape of objects using palpation alone. This is called tactile agnosia. Visual agnosia is inability to recognize objects by inspection alone. Auditory agnosia is the inability to recognize sound without seeing or touching the source of sound. Patients with agnosia may misidentify the dustbin as a toilet or misidentify family members. Patient may misidentify his own image and speak to the image in the mirror, and this is called the mirror sign. Executions. Frontal lobe is responsible for organizing thought and flexibility. It is necessary to assess more complex functions which cannot be elicited by direct question and answers. Patient may be asked to mention, example, as many names of animals or fruits as possible. Lower than 10 in 1 minute is determined as abnormal. 15 is the norm. Some psychologists request a patient to recall as many words starting with a particular letter. Others use a series of digits changing in a particular pattern which must be recognized by the patient to continue the series. Finally, the patient might show parietal lobe involvement, which is indicated by right-left disorientation, finger agnosia, dyslexia, or agraphia and acalphulia, which is called Gerstmann syndrome. Non-cognitive features are common in Alzheimer's disease. Many patients are admitted with paranoid delusions or being robbed or with morbid jealousy. Unlike in schizophrenia, delusions are not systematized. Misidentification syndromes of various forms of delusions, such as delusion of doubles, are not uncommon. In Capgras syndrome, patient suspects a familiar person, example a spouse, to be a double or an imposter. Visual hallucinations are more common than auditory hallucinations. Hallucinations of taste or smell may occur. Depression is a common feature. As illness progresses, mood is one of apathy. Personality changes may occur. They may be aggressive, particularly during hospital admission. Differential diagnosis. Mild cognitive impairment associated with age is usually non-progressive. Studies show 15% of those tested progress to AD in later life. Vascular dementia is usually recognized by relative preservation of personality, emotional ability, stepwise deterioration with long period of stability. History of cerebrovascular disorder and hypertension are also common. With treatment of hypertension, diabetes, and hyperlipidemias, there is evidence of reduced large vessel disease. However, subcortical small vessel diseases involving arterioles are more resistant to treatment. This was called Binswanger disease in the past and was considered to be rare. Periventricular hyperintensities in CT scans are now commonly reported. It appears to be more common. The other disorder that must be differentiated from Alzheimer's is cortical Lewy body disease. They account for about 15 to 20% of all dementias. These patients show Parkinson's features, episodes of confusion, vivid visual hallucinations in clear consciousness, and suffer frequent falls. Other dementias that may enter into the differential diagnosis should be carefully noted. Look out for Parkinson's disease. I have already mentioned cortical Lewy body disease. Frontotemporal dementias sometimes present like Alzheimer's. This is characterized by marked lobe atrophy of frontal and temporal lobe. Syndrome was originally described by Arnold Pick, characterized by onset of personality change with disinhibition, euphoria, socially embarrassing humor, and behavior followed by disturbance of language, perseveration, and inflexibility of thought. So this is characterized by early changes in the personality, and cognitive features come on much later. Currently, the frontotemporal dementias includes Pick disease and other non-AD or non-Alzheimer disease dementias with different pathology, like inclusion bodies seen in motor neuron disease, those that contain tau and ubiquitin, may have family history of other neurological disorders. Characteristic feature, as I mentioned, personality change, cognition coming on later. Euphoria, irritability, apathy, primitive Graf's reflexes or pout may appear, psychotic symptoms are rare. Other diseases to be considered would be Huntington's disease, prion diseases, like Jacob-Creutzfeldt's disease, and other uncommon prion diseases. The most common presentation is a gradually progressive decline without distinguishing features. A group with early onset 65 show more aphasia and apraxia, a rapid course with severe intellectual decline and poor survival rate. A group with extrapyramidal signs with severe functional impairments are associated with psychotic symptoms. A benign group with little or no progression over 4-year follow-up has also been noted. Now, the benign groups are called mild cognitive impairment. Factors associated with poor prognosis: being male, onset before 65 years because they have a strong family history as well, parietal lobe damage, prominent behavioral problems for which they are usually admitted to hospital, severe focal cognitive issues such as apraxia and observed depression. Assessment should include a mental examination with neurological examination as well, cognitive testing, physical examination, blood tests, EEG and brain imaging. EEG may show some slowing. Brain imaging might show the abnormal atrophy of these atrophy changes in the brain. But what is most important is to note that the clinical features are more important in the diagnosis than imaging and other investigations. There are patients who present with severe symptoms of Alzheimer's disease with minimal or no changes in the imaging tests, brain imaging. And there are also people who show severe changes with mild clinical features. There seems to be an overlap, and the main diagnosis should be based on the criteria outlined in the standard classificatory systems. There are a number of classificatory systems, NINCD and ADRDA criteria will be able to make a judgment about probable Alzheimer's, possible Alzheimer's, and definite Alzheimer's disease. Next. The pharmacological treatment today are mainly cholinesterase inhibitors. These drugs improve alertness and function and can maintain cognitive scores at or above baseline for about 12 months. However, they do not modify the underlying progression of pathology. First generation of anticholinesterase inhibitors, Tecrin. Second generation would be donepezil, primistine, galantamine. And there is a third one, NMDA receptor partial antagonist, memantine.